Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
I'm nervous, man.
Nervous.
Thinking of all the times you presented to Kurtan, and you're like, "Oh, it's just like, down this little pathway," and Kurtan is like, "What are you talking about, man?" I'm nervous, man. I love the way that you think about medicine, and like, I think your reflections on your cases are so powerful. They've definitely changed the way I think about how I process patient stories in particular. So I'm like very excited to see what you're bringing today.
I feel the same way.
I mean, I still also have a lot to learn. I think you only get you only get like experience and like see the part of the like I don't get patients that come for like chest pain. I don't get patients that come for like shortness of breath. It's like cardio. So yeah, there's like just so much medicine so broad.
Yeah, and maybe even Jeffrey, I'll introduce you really quick. We're already recording. I think it is curious to hear from our guests like where they're coming from and where exactly they practice. People have kind of brought us varying locations of patient cases. So yeah, I'll introduce you real quick and then have you explain where you're at now, what specialty you do, and maybe kind of like your favorite part about the job. Does that sound good? Something like that?
Yeah, sounds good.
Okay. All right. Welcome everybody. We brought another guest here for a Guestpisode case, another friend of the podcast, Jeffrey Shen, clinical problem solver member, academy member. Jeffrey, you want to unmute and tell us how you're doing, where you're coming from?
Hey, I'm Jeffrey. Thanks so much for inviting me to this. I'm really excited to be here. I only recently learned about this podcast, and I was so excited. I asked Andrew if I could join. Currently, I'm a rheumatologist who's working at Duke University. I have a passion for clinical problem solving, clinical reasoning. It's actually what brought me into medicine in the first place. And as Andrew said, I'm also a member of the Clinical Problem Solvers podcast. I trained in UAB at University of Alabama, Birmingham for both med school and residency. And yeah, that's me.
Thank you for the enthusiasm for our show. Thank you for being here. And thank you for all you do for our patients we send your way with ANA of 140.
Awesome. All right, we can get started. Yeah, thanks so much again for having me here. So, so this is quite of a complex case, and I thought a lot about the different ways that I could present this. So there's going to be a couple different aliquots. Some of them will have tons of workup information, but the first two aliquots will be relatively short. So the first aliquot is when this patient presented first to the hospital. So it's a 43-year-old woman. She has a history of fibromyalgia, inappropriate sinus tachycardia, irritable bowel syndrome, migraine, anxiety, depression, acid reflux disease, hyperlipidemia, and ADHD. She's presenting for 5 days of really bad headaches that she says are located on the temporal side bilaterally. Also, she has been having diffuse joint pains, and they're kind of distributed throughout her entire body and actually affect even her head. And she says that she feels like her jaw hurts and it's clenching, and it worsens actually when she's trying to eat. She also has blurry vision with both eyes and retroorbital pain behind those eyes, which is also new for a couple of days. Muscle cramps, fatigue, a burning sensation in her chest, which she has experienced before with her acid reflux, some diarrhea, and then said that kind of over the past 6 months, she wasn't really feeling too good. She's been having intermittent drenching night sweats and also 10 pounds of unintentional weight loss. So she came to the hospital, and I'll just kind of briefly actually tell you the workup and see what you guys think about this. The inflammatory markers were moderately elevated. They did an infectious workup, blood cultures were sent, viral respiratory panel. They even tested for atypical chronic infections like TB, tick-borne infections, sexually transmitted diseases like HIV and syphilis. Those were all normal. Then, because of these symptoms, they were worried about giant cell arteritis, even though she was quite young. So they actually got rheumatology involved, and they sent a bunch of labs, including ANA, rheumatoid factor, anti-CCP, which was negative. Uric acid was checked because of her arthritis, but it was also normal. They got x-rays of her joints, were all completely normal. They actually got an opto exam. They said that this was just dry eyes. There's no concern at all for something like amaurosis fugax, no concern at all for anything like a vasculitis. It was just dry eyes. And then they even got an MRI of the brain, the orbits, an MRA, and an MRV. Everything was completely normal. A lumbar puncture was completely normal. Neurology said that honestly, based off her exam, there was nothing abnormal. So they thought there's possibly a functional component. And at the end, there was no explanation for her elevated inflammatory markers. So they said maybe this was just a viral illness. Rheumatology said maybe she just had fibromyalgia and a bad migraine that was like exacerbated by a viral illness. They just gave her a migraine cocktail and a steroid taper, and she was sent home. So that's the first aliquot.
Wow, that's the first aliquot, Mike, of a seemingly very complicated case. Yeah, I don't know. Kind of how I'm thinking about this first aliquot, Jeffrey, is what I got for kind of who this patient is when she presented to the hospital is she carried a lot of diagnoses of what I would label functional disorders versus organic disorders. Organic disorders meaning diseases and past medical history that people have where there's a test that you can hang your hat on and say, this patient has this disease because that test is positive. What you listed was IBS, fibromyalgia. I forget if there was another one, but a long list of things where basically there is no confirmatory blood test or imaging test to confirm this grouping of disorders that are really functional disorders. And that's really challenging because a lot of these patients who present with kind of that constellation of functional syndromes can present with myriad symptoms. So when you have someone kind of coming to you with many, many concerns, including headache, joint pains, jaw pain when eating, blurry vision, muscle cramps, you have to really take everything seriously, of course, because you're meeting this patient for the first time. But you're probably trying to dig really hard into that history and see what exactly is different now, because a lot of these symptoms have probably come and gone. But certainly, I think in one of the symptoms, even you said specifically, this is a little bit different this time. So I think when you're seeing some evidence of organic disease, meaning the inflammatory markers are moderately elevated, you're trying to kind of put your finger on what is new and what is different. So I think just taking a step back for aliquot number one, I would kind of redo the history, which Jeffrey, I know you're a master at. So I'm very curious kind of what you get on a re-review of the history because they kind of came to you for a particular question, but really getting that sense of what is going on is going to be important to sift through all this. But use that to basically tackle the objective findings we're seeing here, which is the weight loss, night sweats, and inflammatory marker elevation. So, yeah, Mike, how are you kind of tackling this?
Yeah, I think that a lot of the things you've said are sort of where my brain went as well. I think a couple things to add. Remember that fibromyalgia really is a disease where you are kind of hypersensitive to what oftentimes are just kind of physiologic or sort of the general range of sensations that all people feel, right? But they're perceived as painful. And I've sort of found that that maybe extends to other things as well. And these patients maybe present earlier with organic illnesses because they're just so hyper aware of things that maybe someone else either wouldn't even be aware of in the first place, or maybe it would take more for them to present to care. So, whereas everyone has their threshold of when a complaint, a pain, something they're feeling rises to the degree of coming into the emergency department. And because we all have pains throughout the week and the month and the year, right? And we don't all present. And so this is a disease where that threshold's much lower. And so it's possible that she maybe is actually feeling things before we get laboratory evidence of what's going on, right? I mean, there's a chronology to these things, and oftentimes we can see organic markers before we see symptoms, but that need not be the case. You can have it the other way around. So part of what rheumatology does and good primary care is just follow these patients, right, and see, do they develop something. Um, I think that the ESR and CRP in her age group kind of can't be ignored. She has a lot of past medical history, but nothing that's inflammatory in nature, right? She doesn't have ESRD. She doesn't have leukemia. She doesn't have, right? She doesn't have chronic diseases that would be inflammatory, and so that's really quite abnormal. If she was 85, I think maybe I would not be as worried about that. But she's younger. She's less than 50. Um, so I think those are the two big things, and I agree in terms of history. Um, with these patients who have a lot of various, they're ROS positive, sometimes it's helpful to ask what was the first thing you notice? And then if I can only take away one thing today, what is that thing? Because then you'll get a sense of like what was the initial onset, right? What precluded everything else? And then what today is the worst. And I think that sometimes is helpful for me in weeding through what is otherwise a very long list. Um, because then you can start to fit your Venn diagrams over things. But it's hard if you have 50 Venn diagrams. So those are my thoughts. I think, yeah, more history, and then a really careful physical exam. Um, just in terms of rheumatologic disease, right? So are they losing hair? Are there anything inside the mouth? Do they have rashes anywhere? Actually taking a look at all the joints, asking at least the sensitive questions about, sexual history. Do they have any ulcers or lesions down there? And then just general sort of, was there abdominal exam? Is there any concerns for something in the chest, right? Just like basic kind of broad stuff. And sometimes we order a lot of tests, a lot of labs, but we don't like look at the toes or we don't look at the fingers, right? So just doing those things too are good. So interested to hear. Oh, and then diet. Diet's also going to be important too, because she's lost a lot of weight. Sounds like it's unintentional, but sort of what's her diet like? We know that, all of these diseases that she has, eating disorders can run with them. That would change things if she had nutritional deficiencies.
Okay, awesome. So I'm going to provide some of the next piece of data, which is just the history before she comes to see me, because there's a lot of symptoms that she had complained to her PCP. I will say that her rheumatology follow-up, it seemed like some of her symptoms were getting better, but the only symptoms that she still were complaining of were similar symptoms, fatigue, these fibromyalgia-like symptoms, and they had said that because of her lab workup was negative, this was probably just fibromyalgia, and had discharged her to the primary care provider. Then I'll tell you kind of other things that were happening when she gave the primary care provider the history. Is essentially that she stated that since 2 years ago she hasn't really been feeling well. She actually was hospitalized for a left-sided contact lens-related pseudomonas keratitis, and it was complicated, and she actually eventually unfortunately had a corneal transplant. And then since then, she's had a lot of these non-specific symptoms, the worst of which was this persistent fatigue, but also headaches, joint pains, muscle cramps, heartburn, diarrhea. Initially, they thought maybe she was recovering from her infection, and then they maybe thought some of this was just side effects to the antibiotics, but they didn't really go away. And she was having right upper quadrant abdominal discomfort. So they actually did a GI workup and found that there was cholelithiasis. And eventually she actually did get a cholecystectomy. And after that, she did say that she felt better for like maybe 2 or 3 weeks before all of her symptoms recurred. We actually were able to take a look at the gallbladder pathology, and it just showed gallstones and some chronic minimal cholecystitis that was related to the gallstones. No other abnormalities were there. And because she still had these symptoms of fatigue and intermittent discomfort as well in her eyes with some redness, blurriness, she actually sought care frequently for either the fatigue or the eye complaints. Of course, since she has a corneal transplant, she sees ophtho many times. And every single time they reassure her there's no repeat keratitis, it's fine. A few times she had conjunctivitis, they said probably allergies or viral, gave her some eye drops, told her to start some antihistamines. And then for the fatigue, her primary care did a broad workup. They did the complete blood count, electric panel, renal liver tests, BNP, CNP, those are all normal. They did thyroid function studies, blood glucose, urinalysis, pregnancy test. So their kind of initial broad workup only showed vitamin D deficiency and iron deficiency anemia. I kind of asked her, had she been having any bleeding, and she said that, sometimes her periods were a little bit heavy. So they actually gave her some repletion of iron and vitamin D. But then after even a couple of weeks of that, maybe a couple of months, she said like she didn't really feel better at all. So, because she also had some of these vitamin deficiencies, they wondered, could this be malabsorption? So they checked antibodies to transglutaminase and endomysial antibodies for celiac, immunoglobulin levels. Those were normal. Serum lipase, fecal elastase was normal. They actually even ended up getting an EGD and colonoscopy, and both were normal. And they did random biopsies in the stomach and colon. There was a little bit of mild gastritis in the stomach, but no H. pylori. And then the repeat infectious workup like HIV, syphilis, looking for like chronic EBV, chronic Lyme, those tests were sent. Hepatitis virus, those were negative, and they sent like a stool ONP, strongyloides, and those were all negative. So that's the end of the second aliquot.
Jeffrey, I feel like I write something down like this is what I'm going to ask for, and then you give it to me, and it's normal. So that's yeah, this is a really tough case. Wow, what a tremendous amount of negative workup. I think the only signal we're really getting is malabsorption. So I can understand why they went down that road, considering there was so much other negative workup, right? Um, she got a colonoscopy for that iron deficiency as well, if we thought maybe it was blood loss rather than malabsorption. But right, she's got iron deficiency, anemia, vitamin D deficiency, and weight loss. So if you just remove everything else, that is concerning for malabsorption. And she got better with steroids or no? Like, has she tried to taper off of them? Do you know, Jeffrey?
So yeah, she initially got the steroid taper for this presumed maybe GCA, but like fibromyalgia illness, and actually her symptoms did get better, but then she stopped taking the steroids, and that's kind of when some of the symptoms came back,
Hmm.
and then essentially it's unclear how much the steroids were helping because rheumatology said that probably this is just fibromyalgia, and sometimes that responds to steroids too.
Okay. And does she have, it sounds like she has sicca symptoms, but does she have anything in the mouth? Are there any findings in there? I'm sorry if you mentioned and I missed it.
So sometimes she says that she has oral ulcers, but at the
Hmm.
time of that examination, and the time that I examined her, I didn't find any. But it sounds like a couple times she has what she described as like shallow, painful
Hmm.
ulcers, much like what you would think with aphthous ulcers,
Yeah.
no genital ulcers.
Yeah. Okay. I mean, and I'm guessing that like in addition to the ANA, like double-stranded Smith, SCL70, like all of those have been, low, Joe, La, whatever, all those, SSA. I'm guessing all those have been sent. I ask because sometimes if the ANA is negative, it just doesn't even reflex to those things. But obviously there are cases of ANA negative, right? Lupus and other autoimmune diseases, right? It's not common, but it's not zero. So are those tested for, Jeffrey? Did I assume correctly that they've been done since everything else has?
So yeah, actually at this point, those have not been done yet. They didn't get those because the ANA was negative. But that is a good point.
That's all I probably have to add at this point. I'm going to pass it over to Andrew.
Mike is playing it like a game of chess over here. Uh, yeah, it's always worth asking kind of like why patients are feeling kind of the way they're feeling. So we already talked about how this patient kind of having the functional sort of substrate. She's very prone to feeling a lot of symptoms, but it is curious like why she's experiencing such prominent eye discomfort, it sounds like, because I mean we do expect some dry eyes after a corneal transplant. I couldn't give you all of the postoperative symptoms after a corneal transplant, but it sounds like she went there kind of repetitively after the surgery. So it does beg the question, is there something that we're missing in the eyes that somehow the ophtho doctors are missing? I'd like to think that they thought about this, but I don't know. Maybe if they're just framing her as somebody who just had the surgery and they turn their brains off, maybe we're missing something like I don't know, like a posterior uveitis or something like this. I would have to brush up on my eye diseases to get that framework unlocked. But I'm just asking myself that why does she have these eye discomforts? I think, as you said, Mike, we've already got this kind of GI workup, so I'm not kind of investing too much actually into kind of the GI symptoms. The only thing I could think of GI that can cause such systemic kind of manifestations is celiac disease can do a lot of weird things systemically. You need not have GI symptoms actually to have extraintestinal celiac disease, like arthralgias, gait ataxia from cerebellar attack, really weird stuff. But I'm not sure that everything this patient is describing actually even fits that illness script. I think the highlights are the joint pains, which I'm not sure yet if that is something we can account for with the fibromyalgia. Because with fibromyalgia, I think of these like kind of painful points, like these uh, tender points throughout the kind of musculature throughout the body. But joint pain itself is a little bit different. We know that with the X-ray that there's no inflammatory arthritis because Jeffrey didn't tell us that there were any erosions in the joints. But that doesn't rule out like just arthritis and arthralgias without frank joint erosions. So Mike, you asked for the lupus, specific antibodies. Lupus does not cause inflammatory arthritis, is my understanding. Like it causes very prominent arthritis, but it doesn't actually kind of destroy the joints. I forget there's a specific word for kind of the weird things it can do later on, but it's not erosion. So I would say that doesn't rule it out, Mike, like you said. But beyond that, I don't know if I would invest too much energy into the other symptoms. The reflux is so non-specific. We've already accounted for the GI stuff. The jaw, the jaw symptoms are interesting. Like we throw back to our GCA case. As far as I'm aware, GCA in patients younger than 50 is pretty much unheard of. So I'm not thinking of cranial arteritis, temporal arteritis. There are mimickers of GCA. Syphilis is one of them. Jeffrey has actually taught us about that in CP solvers, but he's telling us over and over again that they got the STI testing here and it was negative. So I don't think it's that. And I know AL amyloidosis can mimic GCA, but there's just so much else going on here that I don't think GCA can like account for. That I think it's got to be something else. So yeah, I think honestly, I said a lot, but I think I'm just landing where Mike is at. I think we just need to find what systemic disease is kind of causing all of these symptoms to understand kind of why they're feeling this way and also understand the eye disease better.
Awesome. Yeah, this is such a complex case, and after even seeing this patient several times over like months to a year, it took a long time to really understand what to focus on and what was going on. So I'll kind of tell you what brought her back to see rheumatology, and actually at this time is when I first meet her. So at the time they continued more workup. Actually, she saw saw an endocrinologist, and they did workup for hormone testing, like could this be menopause or something hormonal. They did LH, FSH, estrogen, testosterone testing. That was all normal. Thyroid function studies, they've like in the past 3 years have been tested multiple times and they're always normal. They even got 8 a.m. cortisol and ACTH levels, and that was normal. At one point, they even sent plasma-free metanephrines, which were normal. And then the other symptom that then they started to think about was, well, could the fatigue be neurological? Because she also like had some complaints of like a little bit of tingling and numbness in her fingers and her toes. So she actually saw a neurologist, and they said that this was a mild symmetric length dependent sensory peripheral neuropathy and was most likely from her previous alcohol use. So she actually had been an alcoholic, where she had actually a hospitalization for alcohol withdrawal, and then since then had been sober for probably the past 6 or 7 years. Said she hasn't had a single drink. Um, and they at one point we actually even checked the PEth testing, and that was negative. During this like past year, she had one urine drug screen show positive for marijuana, but the rest of them were always negative. And she admitted that sometimes she would take marijuana. And initially, she had thought that maybe that was what was causing her eyes to be red, but then it would happen even when she wasn't taking marijuana at all. Um, the other neurological workup came back. They tested for things like amyloidosis, SPEP, light chain ratio. Those were normal. A1C was normal. Actually, her vitamin B12 was like 260, so it was like low normal. So they actually followed up with a methylmalonic acid, which was high, and followed that up with an intrinsic factor antibody testing, and that was negative. So they went back to GI and asked like, could this be pernicious anemia? And at that time, her CBC showed actually totally normal hemoglobin, MCV. They reviewed her EGD, and there's like no signs for atrophic gastritis. So they thought it was like very unlikely. GI thought maybe it was her PPI that she had been using a lot more recently for the heartburn that could have been causing a little bit of vitamin B12, and maybe she just wasn't eating that much of the things that had it. So they just told her like maybe we just switch the PPI to an H2 blocker for now and add as needed antacids. Her other neurological complaint that actually brought her to neurology was memory loss. She said like there'd be episodes where she'd be in the middle of she worked as like a school teacher. She'd be in the middle of a class, and in front of class, she would just completely forget what she was saying, and that really bothered her. So they did a little bit more testing. They did a sleep study. There was no narcolepsy. There was no OSA. Then they did neuropsychiatric testing, and that actually revealed there was a strong psychiatric component. So they referred her to psych, which she had already been seeing. She had already been doing behavioral therapy. They tried up titration for SSRI initially. There was no benefit. Then they eventually tried changing the SSRI to deloxetine because there were some studies that show the deloxetine can help both with some like psychiatric symptoms and fibromyalgia, but none of them worked. And then finally, the reason she came back to rheumatology is she got a new rash on her face that was in a butterfly distribution. And she said it happened when she went out in the sun, and it would worsen, and it would last a couple of days. It was neither tender nor pruritic, but it was disturbing because it was on her face, and she had to kind of go to school, and she was worried about that. In addition, she had some oral ulcers, and again, the sickest symptoms, dry eyes, dry mouth remained. So there was concern like, could this be Sjogren's or lupus? And they actually repeated ANA testing, and it came back positive 1 to 2560. And I'll end the aliquot here.
Oh gosh, I don't know that I have all the criteria memorized, but I mean, right, you're gonna need to get. I'm sure that you got an ANA. I'm sure you got blood work to see if she's got anemia or thrombocytopenia or leukopenia, lymphopenia. Does she have a UA? Right. So I mean, you're gonna look for those things, but I think I'm quite concerned. I mean, I think we were concerned initially for something rheumatologic, and I think now we have a rash, we have all oral ulcers, we have a markedly positive ANA. And then we also have, I don't know if at this point in time she's still having joint issues, but this disease need not all present at the same time, right? I mean, you can have different parts of it that flare in different ways, right? So even within one person's disease course, they can have all the symptoms, but not always all at the same time, even. So, I don't know. I think that you were going to follow this up, of course, with the double-stranded DNA, right? And the anti-Smith, really specific stuff. And then, yeah, I think because of the sickest symptoms, you're gonna get the SSA and SSB, and probably you're gonna send other stuff too, because that's how it always works when you order these tests. They just reflex to a ton of stuff that you may not have even thought to order. Um, but I don't know. I think I'm probably anchoring a bit, but I think it just seems to fit pretty well. Um, and I guess if she has ulcers now, I think the other thing that'd be helpful here is like tissue of something that seems to be pathologic. And so if she had like oral ulcers right now, maybe actually with the weight loss, her age, I think that alone probably buys you a biopsy. But that's something else. I think the tissue there could be helpful. I don't know that it explains a lot of this because I don't necessarily know how that would explain the malnutrition or the malabsorption, weight loss component of things. But I'm gonna stop there and hear what Andrew has to say, but I think it makes a strong case.
Yeah, just going back to kind of the idea of functional versus organic and the idea that, diagnosing a rheumatologic disease takes time. Jeffrey, you teach this really well in our academy sessions. By definition, most rheumatologic diseases are chronic. So they're very hard to diagnose up front until you kind of start seeing patterns of symptoms and as things evolve. Mike already asked for follow-up. I think we kind of have it in this case. So what I'm really wondering is, yeah, what are kind of the other sequelae that may be either serologically visible now, which we just talked about all of the serologic testing for lupus. Double-stranded DNA is very, very specific for lupus, but also like radiographic pathologic evolution of things. Like I said earlier, I'm not expecting to see erosions if we were to do like a repeat X-ray of the hands, but are there cytopenias? We could send a UA and see if there's any proteinuria, hematuria. The GI symptoms are actually, and I'm now eating my own words, the GI symptoms are kind of interesting. There are gastrointestinal manifestations of lupus. Most dramatically, it can cause mesenteric ischemia by two different mechanisms. It can cause like a TMA, and it can also cause mesenteric vasculitis. That's obviously not the case here because that's like you're coming in crashing with an ischemic gut, but it can cause like lupus enteritis. So if we were to like rescope this patient in a month with worsening kind of abdominal discomfort, diarrhea, and we were to redo a biopsy now with the biopsy, show some inflammation that could be consistent with lupus enteritis. It can cause esophageal disease by a variety of different mechanisms. If there's a myopathic component, you can imagine the esophagus has muscle inside of it. So that can explain reflux. If there's a mixed connective tissue disease component with some fibrosis, then that could also cause like a reflux as well. And beyond that, the neuro stuff, I mean, even though she did the neuropsych testing, I've learned from morning reports really like neuropsychiatric lupus is basically like a diagnosis of exclusion as far as I'm aware. I don't think there's a good way to definitively prove it. You kind of have to rule out everything else. But I think what is on all of our minds is we've kind of ruled out everything else at this point. So now it is kind of interesting. Is this like brain fog of lupus in the brain? If we were to put her on treatment, would that get better? And yeah, let me just take a peek at the note for other symptoms she was having. The eye stuff, I would still need off those input. I'm sorry, guys. I'm not going to be able to teach you any pearls on eye pathology today. But we know that lupus can do eye stuff. So yeah, I think my brain is just wondering how has this evolved in the pathology or the radiology if we were to redo some of this stuff. I don't think we need to do any of that because I would just do what Mike would do and send the specific serologies. And if I have any questions after that, I would just go to Jeffrey for help.
Okay, awesome. Now I'm about to tell you the physical exam, and then the workup, and which is going to be very very interesting. So on exam, she was actually very tearful during the whole time. I think she was just very anxious, worried. That something wrong. She felt something wrong was going on, something was missed, and but she was in no acute distress. She was tachycardic to 100. But otherwise hemodynamically stable, no fever. Her rash on the face, it was erythematous. It was a little bit flaky. Honestly, had some telangiectatic components, and it did spare the nasolabial folds. A rash like this is much more suggestive of rosacea than with lupus, but it was in the butterfly distribution. There was also no other rash or area of alopecia on her scalp, which can sometimes occur with lupus. She actually did have some mild conjunctival injection, although she didn't really have much blurriness of vision or painful ocular movements. I looked in the mouth. There was no oral ulcers or pharyngeal erythema. But she did have bilateral mildly tender cervical lymphadenopathy. Maybe it was about 1.2 centimeters, not firm. And there was no goiter. Cardiopulmonary abdominal exam was normal. Her joint exam was interesting. She actually had synovitis of the left knee and enthesitis of the right Achilles tendon. And then she had positive signs for a carpal tunnel syndrome of the right hand, and a little bit of decreased reflexes, but no motor weakness, no cranial neuropathy, no focal deficits. She was complaining of some nail changes. There was no pitting or splinter hemorrhages. I looked because she was complaining of Raynaud's, but there was no evidence of abnormalities on nail fold capillaroscopy. And it was also notable that she has a history of ADHD and does take amphetamines, which is a very common cause of Raynaud's as a medication. The other thing that actually was abnormal on her nails was that there was a lot of vertical ridging of her nails. And other than that, she had a little bit of 1+ pedal edema bilaterally. Lab studies, interestingly, there was neutrophilic leukocytosis. I believe it was mild, like white blood count was like 14, 78% neutrophils, no lymphopenia. She had hypokalemia with mild metabolic acidosis. And then I sent a broad workup, and essentially all of it returned negative again, except for ANA was 1 to 2560. Double-stranded DNA was actually positive, mildly at 80. The cutoff is 24 at our institution, so 80 over 25. The rest of the ENA panel, like SSA, SSB, entire thing was all negative. RFCCP negative, antihistone was negative, complements were normal, urinalysis, urine protein was normal. An ACE level actually came back elevated. I don't usually check an ACE level, but for whatever reason for her, that I sent that lab, and ACE stands for angiotensin converting enzyme. So sometimes I send that for like sarcoid. And then because she had all these unusual symptoms, diffuse symptoms, unintentional weight loss, night sweats, lymphadenopathy, I actually got a PET CT. And the PET CT showed that there was mildly hypermetabolic, mesenteric, and retroperitoneal lymphadenopathy, as well as right-sided pelvic and inguinal lymphadenopathy. They said it looked like it was mostly reactive. The brightest spots were kind of on the mesenteric and pelvic lymph nodes, but the mesenteric lymph nodes were too hard to get. So they decided to get an excisional inguinal lymph node biopsy, and that revealed essentially reactive lymphadenopathy. I discussed with the pathologist many times about, could this be lymphoma? Could this be something else? They did a lot of the stains. We looked for IgG4. There was no granulomas. We looked even for like rare diseases like histiocytosis, which can very rarely present with a reactive lymphadenopathy. That was negative. There was flow cytometry done that didn't show any evidence of malignancy. I looked for T cell rearrangements because sometimes T cell lymphomas can be sneaky. That was negative. The only thing that was positive was an EBV stain. And that was very unusual because she only had this kind of right-sided peripheral lymphadenopathy and mesenteric lymphadenopathy. So after discussing with the pathologist, he thought that this was most likely EBV-associated reactive lymphadenopathy in the setting of immune dysregulation, and had said possibly this could be seen in lupus as it's been reported in case reports. And then we sent EBV testing, which was positive for the IgM, IgG of the viral capsid antigen, but negative for the EBV EA antigen IgG, which is a really confusing set of kind of labs which indicate either false positivity or reactivation of EBV, or she had mononucleosis some time ago and it's like months out now. EBV viral load was checked and that was 0. I really wasn't sure what to make of this, so I said maybe this is lupus, although it's a little bit unclear. But I said, let's just start hydroxychloroquine. Maybe we can start some methotrexate. She didn't tolerate the methotrexate at all. She just continued on hydroxychloroquine, but none of her symptoms actually improved over the preceding 6 months. And her symptoms of fatigue, migraines, brain fog, neuropathy, and anxiety were kept getting worse. And there's one aliquot left after this.
Andrew, go ahead, because I think that's most of the tests that exist in our hospital.
Jeffrey, what are you withholding in the next aliquot? All right, I'm just gonna phase one of this discussion just gonna be kind of making sense of everything Jeffrey gave us, which is a lot. Hypokalemia, metabolic acidosis. We weren't given an anion gap, so I'm gonna translate that into this is a non-anion gap, metabolic acidosis and hypokalemia. I know that some systemic diseases can cause RTAs, which I don't have memorized, but as Jeffrey was talking, I pulled up my notes on this. Lupus can cause type 1 RTA, which is an issue basically at the alpha intercalated cell location. It will also decrease the K. So this will get you a hypokalemia. And Sjogren's and rheumatoid arthritis are also on that list. Lupus can also cause a type 4 RTA. This is basically just hypoaldosteronism. So your principal cell is just not working. And actually, type 2 RTAs, I don't see any rheumatologic diseases on that list. So just wondering if there was no, vomiting illness, diarrheal illness when those labs were sent, if that test were to be repeated, is that signal that whatever this thing is also attacking basically, one of these lesions inside of the kidney. We got neutrophilic leukocytosis, in the realm of systemic diseases. It does make me think of kind of auto-inflammatory disorders. These are like the periodic syndromes like FMF, which, of course, we're not getting that story of this is someone who's here with Q3 to 21 day fevers that go away with painful serositis, stuff like that. Lupus, yeah, I'm in the company of a rheumatologist, so Jeffrey, don't hurt me. I believe it's this kind of like mixed autoimmune, auto-inflammatory sort of disease. So if this is kind of that auto-inflammatory face of lupus, that neutrophilic leukocytosis could be representing that face, perhaps, and we're just not seeing that lymphopenia component. And when I saw the double-stranded DNA being positive in the lymphadenopathy, I had the same questions I think Jeffrey had. Is this a lymphoma that's driving autoimmunity? And is this something that's spitting out lots and lots of antibodies, and that antibody craze syndrome that we've talked about in a prior episode with the cocaine vasculitis case that Mike presented us? So I know after that conversation that Jeffrey had with the pathologist that it doesn't seem that is the case. Of course, this could have just been a bad node that we went for in the rule outs of lymphoma with an excisional biopsy, but I'm just going to trust Jeffrey here that this was not a lymphoma. He asked for all the right things in terms of ruling that out with excisional biopsy. So then kind of putting that all together, I was thinking, all right, if this is like EBV that's like living in the nodes, even though it's not in the blood, that's kind of weird, right? Like it shouldn't really be there. Is this like the immune system kind of failing to control EBV? And I mean, I hate to do a recency bias, but I literally spent all week actually reading about kind of the interplay between immunodeficiencies and autoimmune disorders. And I can't say I have half of that list of diseases memorized, but the idea is there are some immunodeficiencies where, that word in itself, immunodeficiency, makes you think you're just prone to infection, like someone's coming in with recurrent infections over and over and over again. But many of these actually also cause escape of autoreactive lymphocytes that cause autoimmunity. So CVID, common variable immunodeficiency, is actually a very common immunodeficiency that causes not just hypogammaglobulinemia and recurrent infections, sinopulmonary stuff, but it's often associated with lupus. Your lymphocytes, the ones that are autoreactive, can cause a lot of these manifestations. So there are many, many other sister syndromes of immunodeficiency where there's a break in peripheral tolerance, central tolerance, or basically accumulation of self-antigens, where kind of the downstream effect of any of those breaks in immunologic development is autoimmunity, basically, and self-attack. So that said, I'm not going to be able to spit out again all of those lists of diseases, but if Jeffrey is telling us he's not confident in this diagnosis, but it's still based off of the weird serologies and kind of the EBV positivity, and we can't make further progress with like antibody testing, I think the last step for this patient is next gen sequencing to basically like get a sense of is there a mutation that's driving immunodeficiency and autoimmunity at the same time. And I guess it's also worth saying out loud, I think that treatment failure is another reason I bring that up, because as far as I'm aware, the traditional treatments for these don't always solve kind of the underlying problem and the break point in the immunology. But maybe I'm really off here. I'm going to end there. I'm excited to learn from Jeffrey. Right. Mike, any final thoughts?
So most of for some reason my internet connection went out there, so I missed what I'm sure was a fantastic a fantastic bit of information. I think that you had mentioned CVID, and so I think you probably already mentioned it, and just immunoglobulins, I guess, would be the other thing to check quantitative. But I imagine that's what was said. I'm sorry that I missed it. But yeah, no, Jeffrey, teach us. I'm excited to hear even how you
Yeah,
got to the diagnosis and then what it is.
yeah, definitely. And maybe I can give one more a piece of information and see what you guys make of it before I reveal the diagnosis. But just as Andrew was mentioning, I had a actually was discussing this case with a couple of other members in our academy. Like, could this be some type of immunodeficiency? But what was strange is that there's no other like recurrent infections. There's no like recurrent viral, recurrent bacterial infections. But this EBV thing is very weird. And there are definitely immunodeficiencies that mainly cause EBV to last for a really long time. But I just wasn't clear that going that route was the correct route or not. Either way, I sent the testing, which we over here send a flow to look for cells, specifically some T cells to see if they're abnormal, and then also to look for immunoglobulins and antibody responses to vaccines. And actually, all of those returned normal. And then then I kind of was thinking, this patient has a whole lot of different symptoms. Perhaps the eye symptoms are still not well understood. And so I actually happened to send a vitamin A, and the vitamin A level was low. And that's the final clue I'll give you guys and see what you guys think before I reveal the diagnosis.
Oh man. Uh I mean, my first reaction to that is that a complication of something that's going on, or is that somehow driving everything, right? So vitamin A being low, it's a fat soluble vitamin. If there's exocrine pancreatic insufficiency with fat malabsorption, of course, that's going to be an issue. But y- you know, I don't hear much about like chronic exocrine insufficiency. So if there really is no pancreatic exocrine insufficiency, then we're still losing the vitamin A somehow, and it kind of gets back to malabsorption. So again, it's something kind of attacking the ileum where this is done. Mike, is it the ileum where this is absorbed? The ADEK, somewhere in the small bowel. Um, so yeah, I feel like it's a consequence of what's going on, but if it's the cause of stuff, I mean, vitamin A is used in like epithelial linings, so it could explain why the eyes maybe are like failing to heal like after the surgery. And I've read about weird stuff like in the bladder where if the vitamin A is not available, you can have kind of like chronic inflammation in the epithelial lining of the bladder. I can't remember if that was a Gurpreet case or not. It was a Nejm case of vitamin A deficiency though, doing that. But no, I just have to read more because I'm still lost.
Yeah, I just looked up full transparency. Chronic chronic active EBV. And it something's fit, like the lymphadenopathy. But it really there's like fever, splenomegaly, hepatitis, like those things we're just not seeing here at any point. And it looks like EBV can cause kind of trigger autoimmunity. It just, again, this is me just reading to you. But I'm not sure. I think that it still seems most likely that there's something more malabsorptive that is causing B12, vitamin D, vitamin A. But the vitamin A deficiency causing some of the epithelial symptoms is interesting. Interesting thought, like chicken or the egg thing here. But no, Jeffrey, I'm interested to hear what you found last. I don't have anything else to really say here. It's a fascinating case, and I'm wondering if maybe one test that we got was either there's a sampling error or there's something about the testing characteristics that I'm not aware of. Maybe that the answer's been there all along.
Yeah, so I was right along there with you guys. Like, the same thought, like it sounds like malabsorption, but I don't know what's going on. All of her tests has been normal. I mean, maybe it's just lupus, but now that I have another signal, like maybe we repeat the testing there. So just on the same thoughts, like this whole thing looks very similar to lupus, but then there's also some nutritional deficiencies, and I guess for diarrhea and uh, abdominal discomfort that's attributed to IBS. It sounds just like kind of how you guys mentioned before, like celiac disease. I looked back and her testing; she's been tested 2 times for that. Did the whole workup; it's always been negative. So I actually repeated the test for celiac. Unfortunately, it came back negative again. And then I actually sent her directly to GI and also to get an EGD with a small bowel biopsy. And the duodenum was normal, but the biopsy showed patchy villus blunting, lamina propria lymphoplasmacytic expansion, and increased intraepithelial lymphocytes, which were non-clonal, diagnostic for celiac disease. So the final diagnosis was celiac disease. And actually, the last time I saw her was about a month ago, and she had been on a gluten-free diet for the past 3 months, and almost all of her symptoms, the rash, the myalgias, headaches, everything has gotten significantly better.
Wow. Wow. Mike, you called it with the testing characteristics and evolution.
Yeah, anytime you have like this big pan negative workup, there's the possibility, of course, that you don't know what's going on and you're not sent the right test. But as we get more and more layered on top of each other, it does sort of raise the question of, is there something about the test? Is in terms of just sensitivity, specificity, particularly with biopsies, right? Um, I guess was that first biopsy in the EGD. I wonder if it was just the stomach and that was it. They just went for the stomach. They didn't actually extend it into the small bowel, which is interesting because actually the bowel is what probably matters most when you're thinking about malabsorption. So that is interesting if that was not done. But yeah, it's a good thing to always sort of just reinterrogate what's been sent and then how much those things exonerate or rule out problems or rule in problems. So, what I'd love to know is how does celiac cause the double-stranded DNA and the markedly positive ANA? That's not a mechanism I'm familiar with. And then I don't know if there's any association with the EBV and celiac. So I think those would be cool things to know if there's connections there. But yeah, no, I common thing common, right? But atypical presentation. So that's what we do here.
Yeah, so it was a fascinating case, and it was really incredible. I actually don't have a great explanation of why her ANA is so positive and why her dsDNA was positive. We actually rechecked and her DNA is now back to being negative, although her ANA still remains positive. Um, I don't have a great explanation besides that celiac has some autoimmune component. It is noted that in patients with celiac disease, you can get a positive ANA. Usually, when we think of a really high positive ANA, that's not rheumatologic. It's more like hypothyroidism. But in this case, it may be that it's related to the celiac. It may be that it's related to the EBV. Reading more about EBV and people with celiac, the worrisome complication for celiac is in refractory celiac, which can lead to enteropathy-associated T-cell lymphoma. And it looked like there were some studies that showed that patients that had that type of T-cell lymphoma usually had EBV in the lymph nodes that had the lymphoma, although there was no clear understanding of whether that's just an association, is it related, does it cause problems or not. So I think some of the problems here are still not completely understood. But given the fact that all of her symptoms got so much better, I think that the best unifying diagnosis for this was just a very tricky to catch celiac disease. And partially, it was probably, I would guess it's probably because she intermittently was having gluten in her diet and it may not have been consistent. When looking at the testing for celiac disease, it seems that it's actually pretty good, like 80 to 90% sensitivity. And her most recent TTG test actually, so our cutoff here was 15.4. And when looking at her TTG, it was actually 15.3. So I don't know if that was actually just maybe barely below the cutoff. And if it was a little bit higher, it would have made a difference. She saw GI, and interestingly, their first thought was also let's at least make sure it's not celiac because it can sometimes be challenging to diagnose. She's had persistent iron deficiency anemia, multiple other vitamin deficiencies. It would have been a very challenging situation if we did not end up getting that diagnostic procedure. But just another case that was so incredible and humbling and taught me a lot about how this disease can present.
Never let us down, Jeffrey. In doing a cognitive autopsy, I'm thinking of like little clues sprinkled along the way that fit the celiac script really, really well. So I have my own script up here for celiac disease. She had the classic malabsorptive stuff the whole time. I wasn't really tracking it and flagging it as kind of clinically significant this whole time because I just thought there was enough other stuff going on that I didn't really want to incorporate it. But that lymphadenopathy actually is really interesting because it was very well. Actually, she did have the cervical. Okay, she did have the cervical lymphadenopathy, which is a bit far from the GI tract, but kind of like occult GI lymphadenopathy, like around the mesentery and the pelvis. I think that's pretty common for like tricky celiac disease because like the inflammation is kind of like near the gut, right? So it makes sense that those lymph nodes are going up. You can even have like focal hypercoagulability, like portal vein thrombi near the gut too. Neuro, we talked about how it can do cerebellar stuff. Did you think that any of the brain fog she was having, Jeffrey, or anything like that was related to this, or no? She just had this kind of laundry list of functional disorders.
I think so because actually all of her, a great deal of those symptoms have now improved. And actually, just even talking with her, she seems like a different person. Like even the anxiety is pretty much gone because she used to come in, she would be crying, she was very distressed, she had a lot of anxiety. She still says that like those symptoms are there, but when I talk to her, I really can't tell like from speaking with her and listening to her. And then I'm also kind of curious that like as you were mentioning, vitamin A deficiency affects the mucosa, right? So when we have patients that have Sjogren's with dry mouth, and the reasons that Sjogren's commonly causes cervical lymphadenopathy, part of it is thought to be because the mucosal irritation. So I wonder if the vitamin A deficiency here was causing some dry symptoms, maybe a little bit of irritation in the cervical lymph nodes as well.
Wow, so interesting. Yeah, I mean, I think my last takeaway is everything. All of your testing is dependent on pretest probabilities. So for anybody where you have a high pretest probability for celiac disease, you don't stop at the serologic testing. You need to get the endoscopy, specifically at the duodenum level to look for the villus blunting, like you said. There are other things that cause villus blunting and villus atrophy. But yeah, that's crazy, Jeffrey. I'm shocked. Thanks for bringing this case.
Yeah, thank you very much, Jeffrey. Do you know, was she changing her diet intermittently? Because I mean, the TTG is good unless they're adherent to a gluten-free diet, and then that test will often be negative, falsely so. So I know if just, she wasn't doing it because she meant to, but if there was I just don't know if that was present or not, if you had any of that history.
Yeah, actually, I did talk to her after it was diagnosed about or her diet, what she was doing with her diet, and it looked like because of the IBS, she had been like researching online, so she had been changing to different types of diet. Like she went to Mediterranean diet for a month, then went to like keto diet, Palo Alto diet, like different diets. And I didn't even think about asking that question, but in retrospect, it would have been an important key question to ask, just because I don't. It's just not something that I usually ask about is like how your diet is.
Yeah, I wonder if at the random points in time that that test was being sent, she had just not exposed herself to a lot of gluten at that time. Of course, then her symptoms should be better also as they're sending that test, so that would not make a whole lot of sense. But yeah, I mean, I'm looking and 95% sensitive is what I'm finding in this Lancet review from 2022. So, but remember, right? That's not 100%, it's 95, so 5%. Thank you. This is a humbling case, and I agree that the key here was just to go back and reinterrogate the tests and reinterrogate kind of the patient, to be honest. So thank you, and good on you getting that second EGD. I think a lot of folks would have said that that's the end of the line, um, but yeah, good on you.
Yeah, I think this was a really fascinating and just incredible case. And it's something that I can reflect on over and over again. So, thanks so much for inviting me and letting me share this with you. I definitely learned a lot throughout this case as I was struggling to understand what was going on. And I hope we can all enjoy and learn from reflecting on this case.
Awesome. Thank you so much. Thanks to our listeners tonight, or whenever you're listening to this. And we'll see you in a couple weeks, everyone. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.